Hi.
راحت مدري كيف انت روحت.
Hi,
Hey, Sharifa.
how are you?
I'm good. How are you?
I'm good.
So nowadays, pharmacology is done.
No, we still have one more lecture maybe? No, this one.
Yeah, so we have, apart from this session, two more resource sessions and one lab session.
Yeah, so
So
three.
three, yeah, totally three. But these three, other than lab, you can consider like something not that important, because these are all something peripheral issues
So you
for
have to study them or?
understand the concepts, yeah, but put more efforts towards the earlier
Oh, okay.
sessions. Do they have some exams or what?
Foundation,
Foundation.
they have their exams, and over there is year one exam.
Year one is happening.
And also we have exams.
Who? Oski, no? You have today Oski. Who told me? Ahmed told me yesterday. Okay. So, in the afternoon, right? Okay. Just 3 more minutes. Yeah. All right, so pharmacology, I mean, unit 1 is going to come to an end, right? So this is the first time you are getting exposed to so-called problem-based learning, PBL, correct? Yeah, so we gave you a lot of problems, and then we wanted to see you how you are handling them, correct? In pharmacology, other than this session, we have 3 more sessions, 2 resource sessions and 1 lab session. In that lab session, what I have planned is, because you did not take the formative exam in OSPI related to pharmacology station, so I will be displaying 3 or 4 tables, like which will mimic the stations that you are likely to have it in the exam. The questions, I am not leaking the questions, don't misunderstand that, okay. It is just to give you an idea how questions are likely to be in pharmacology OSPI exam. So 4 stations will be displayed, and you will get an idea like how the question is going to be. And during that lab session, I will also show you what are all the ways by which you can write a prescription. So what are all the acceptable ways by which you can write a prescription, which is not only applicable to this unit but to any unit in phase 2 of your MD curriculum. Yeah. So these are the 2 key items in the agenda during the lab session. So it will be useful if you can attend the lab session. All right. So with that, let's begin the today's session. Good morning to every one of you, and good to see you in the third last pharmacology resource session for this unit. So this week the problem that's been discussed for you is a patient with lung cancer, correct? Sorry.
Yeah, we'll just do the space ID and that.
Okay. Do that. Do that. Turki Yusuf, anyone? Huh?
It's a squamous cell carcinoma.
Squamous cell carcinoma. Just make sure the video is on.
It's on.
It's on?
Yeah.
Okay. That's why I was wondering how come there were more students. So after the Attendance will come to know the real number, isn't it? Haan, Jumana.
We have to fingerprint here and downstairs in the lab.
Both?
That's what they told us last week when for the dry lab.
Oh, is it?
That's what they told us last week.
So what do you want to do?
2 minutes, we'll go and come.
You want to go and come? Do the boys know that? Jumana is saying that you need to go down and keep a fingerprint there.
That's what they told me in the administration.
Okay.
Because I told them.
What is
they
the
said-
point? Yeah?
They said as soon as you see lab in the schedule, it's in the lab. That's what they said.
All right. So give a try and come. We'll wait for you all then. Yeah? Year 2, right?
Yes.
I think you need to also go down and keep your fingerprint and then come back. Yeah, that's why. Yeah, so just follow the. You don't want to go? Sure? Okay. Ah. Today. Ah.
It is bacterial static, right?
Macrolides.
Yeah.
Ah, ah.
And high dose, it's bacterial
There are some evidence that at high doses, for some bacteria, it can act as a bactericidal. But if you are asked a question in general, whether macrolides are bacteriostatic, yes, exactly. Guys, for those of you who are just turning up, I think you need to also go down to the dry lab. Yeah, you are aware of it, right? Yeah. All right, all right. Take care, take care. Better you also keep it and come, no? Why you want to waste your attendance? Nah? Very rare to see a student like you. Because I think half of them are for attendance. They will just vanish from there. Yeah, I don't see any rationale. Why should it happen at two places? I also don't know the logic actually. You have to go down also, looks like. You did it there? Yeah. Ah, okay. Then you are. And okay. Year 2? No, no, year 2. See, come here. Keep it like this. Year 2, lecture 2, lecture hall 2.
It's not lecture, it's the pharma lab.
Oh, then in lecture 4,
Okay, thank
hall
you.
4. Hi, I'm good. How are you?
Fine.
Come. You gave your attendance down? No. So because they have gone down also, it looks like you
Down?
need to give in the dry lab also and come back.
Okay.
Huh? You gave your attendance down? Ah, okay. Yeah, that's what I heard from you, like students. Jumana told me that. I'm not aware. Yeah. All others are fine, like all other pharmacokinetic sessions are fine. You don't have any doubts? Very rare to see a student. That's why I was praising her. She took it attendance as the least important. Yeah. But you should ask them, what is the logic? When the session is happening here, why should all you also?
She said,
Oh.
if you see the word lab, it means you have to fingerprint in the lab. Whether it's dry or wet, it's lab.
It doesn't make any sense, isn't it? So you had I totally agree, Turkey. Maybe through your representatives, through Abdullah and I don't know who is the representative there, just try to bring this point to their attention. Yeah, I'm sure they will address it. They should at least tell the logic behind in keeping it both the places. Dry lab is not as spacious as this, right? In the lab down, there are no rooms spacious like this, correct? There are 4 such divisions are there. But each will be like maybe a quarter of the space? Quarter of the...
So there are 4 labs, 4 rooms.
The space of one room is like a quarter of this maybe? Half of this. Okay. Okay. Hey, Mohammed. I'm good. How are you?
Thank you. تفضل. أنا بعرف بالقص هي حكي كذي ولا لا؟
All right. I think most of you are here, so let's begin the session. Yeah. So welcome back. And this week the problem that's been discussed for you is a patient presenting with symptoms and signs of cancer, and in the second last trigger there is a mention on the management. How was the patient managed? And there was a phrase called anti-neoplastic chemotherapy. Correct? Hi. So the objective that comes out of this sentence is, what is chemotherapy? So as a doctor, there are some fundamental concepts that we need to understand when it comes to drugs used for treating cancer. Just one point to be made clear to you: you are not going to treat any cancer patients. Cancer is a specialty on its own. So people get trained for 6 years after the MD to become specialist in treating any cancer. So as a general practitioner, after MD, completing MD, you might be seeing cancer patients who are being treated by a specialist, but they may come to you for minor problems. In that case, you should be able to identify that they are related to the anti-cancer drugs and how to treat those minor ailments which the patient is presenting with. You are not going to change the dose of any anti-cancer medications. You are not going to understand the PK, pharmacokinetics or pharmacodynamics of anti-cancer medication. That is far, far, far above the scope of MD program, right? So here you need to understand just the fundamental concepts and how anti-cancer drugs are special compared to other drugs. So these are the things that will be objective in today's session. Whenever you treat a disease, the first thing that you should ask is, what are all the therapeutic goals to be achieved in that patient? So if you have a patient presenting with cancer, in some cancers it is possible to achieve cure. Are you aware of any cancer where cure can be achieved with which cancer? Very good. Breast cancer. Okay, very good. Any other? Well done. Yes? Skin cancer. Very good. There are some restricted skin cancers which can be cured if you identify them at early stage. Very good. So breast cancer, skin cancer, testicular cancer, ovarian cancer, prostate cancer. So these are cancers which, provided you identify them early, cervical cancer, identify them early, right? There is a cure that you can achieve in the patient. But most often what happens is patient is unlikely to visit a hospital if he or she doesn't have any problems, right? We never go to visit a hospital once a year. Only if we find some problem, only if we have some difficulty, then we go to a clinic or a hospital to address that problem. Because of this, cancer stays silent. It's a silent killer. It stays silent for a long time, and suddenly on a day it erupts. It causes the symptoms and signs. So by the time it is identified that the patient has a specific cancer, it's actually late to address with any treatment modality. So many a times cure cannot be achieved. In that case, your goal might be, okay, I cannot cure the patient, but is there a way that I can at least stop the progression of the disease or reduce the rate at which the disease is progressing in the patient, and is there a way that I can prolong his lifespan? Can I increase his survival, chances of survival by few months or few years? So that is the next goal if you are unable to attain cure if the patient presents with a late, at the late stages of the disease. And it is not only enough if the patient lives longer. Quantity is one, but what is more important than quantity is quality. So not only the patient should be living longer, but while he is living, you try to address issues that can improve his quality of life, so that his quality of life stays as close to normal, and then he is satisfied, right? And for doing this, you need to see what are all the complications that are likely to happen in that cancer and use modalities to reduce those complications, as well as the symptoms the patient presenting with, and you can use drugs to curtail those symptoms. So these two will help you to prolong the lifespan as well as to give a better quality of life. Most cases it is these four that you will be aiming to achieve. Very rarely the cure is possible. Yeah, so that's very rare. It is not typical, it is very rare. Traditionally, the cancer is treated by using drugs. They fall under what is called as chemotherapy. Chemo means using chemicals to kill the cancer cells. Chemotherapy. Other than chemotherapy, in some cancer disease, you can also do surgery. Let's say you have a patient presenting with skin cancer. You said skin cancer. There is a cancer here, right? So the surgeon can do a surgery to remove this mass. So surgery is an option in some cases, particularly in solid tumors. There is a possibility. Adenocarcinoma of colon. You can see the site of colon where it is being changed to a cancerous state, and you can resect. You can cut it and take that part of the colon. So surgery is also an option. In some cases where the drug is unlikely to give the best result, attacking them with high dose radiation. You have studied in your year 1 physics, correct? There are different types of radiations. You use low intensity for investigation purpose, high intensity for killing the cells, particularly cancer cells. So that forms radiation therapy or radiotherapy. These are the three traditional ways of treating cancer. Chemotherapy using drugs. Some cases you can do a surgery to remove the bulk of cancer cells, and in some other cases they are sensitive to radiation, and you can use radiotherapy. But the drawback of these three traditional modalities is they are so non-specific. They not only, particularly the chemotherapy and radiation therapy, is they not only attack the cancer cells, but they also cause disturbance or death of normal cells. And so patients are more likely to have a lot of unwanted adverse effect. Because of this drawback, in recent years, we have several novel approaches or novel treatment modalities. One is targeted therapy. Why does cells become cancerous? What is happening basically that makes them to proliferation? Why do they abnormally proliferate? Mutation. So, most often cancer cells will have a mutation in the protein, a mutation in the checkpoint regulator, a mutation in the gene which is different from normal cells. So, if we can identify that, and if we can make drugs which are targeting only that mutated proteins or mutated enzymes or mutated genes, then those drugs are unlikely to affect the normal cells, and it is likely that only the cancerous cells will be targeted. So, that is the principles behind using what are called as targeted therapies. Another advancement has happened in stimulating the immune system of the body, because you know CD8 cells, what are they also called as? Cytotoxic cells. Why are they called cytotoxic? They kill the cells when it is unwanted to our body. Cancer cells are unwanted, right? So, physiologically the CD8 cells have to protect them, but so much proliferation has happened that the CD8 cells are not empowered. They do not have adequate ability to kill those cancer cells. So, by using drugs, if you can stimulate CD8 cells and they go to the cancer cells and kill them, again you can make them more specific and you can reduce the chances of adverse effect, because CD8 cells are not going to kill the normal cells, they are going to kill only the unwanted cells. So, that is a part of what is called as immunotherapy. In liquid tumors, we do not say liquid tumors, but for you to understand, we have tumors of the blood cells, leukemia, lymphoma, right, particularly leukemia. So, they are tumors of blood cells which move in the circulation. So, for that we have a bone marrow transplantation. So, this is a treatment option for liquid tumors. These are all, as I keep telling you from the beginning, highly specialized. You as a doctor, as a general practitioner, do not have to put much efforts to understand in depth, and you will be seeing these specialized treatments particularly in unit 9 when you are in year 4, and about leukemia in unit 6, and there are some tumors which are responsive to hormonal changes. Particularly you said breast cancer, prostate cancer, testicular cancer. These tissues are dependent on hormones for growth, for replication, for multiplication. So, by some strategy, if you can prevent the hormones from stimulating them, you can reduce the rate at which they grow. So, they are called as hormonal therapy, and you will be seeing them in unit 4 next year as well as in unit 9. So, in this unit, you need to understand only the core concepts of anti-cancer drugs and how are they special compared to the other drugs that we use it for different diseases. This, in general, whenever you are treating a patient, right, how do we decide upon a dose of a drug? By VD. Okay, good. VD. Is VD alone enough for you? Therapeutic effect. So, you have to, VD is in fact dependent on the concentration that you achieve, right? And the concentration is dependent on the dose that you give it to the patient. So, dose and the therapeutic effect. And if you remember, we plotted a graph in the pharmacodynamic session with dose on the x-axis and effect on the y-axis, right? Dose response curve. And then we plotted 3 curves, one for therapeutic effect, toxic effect, and in animal studies. You can also come up with the dose ranges that gives, that can kill the animal, lethal effect. and then we derived a parameter called therapeutic index, so called TD50 over ED50 in humans. Just, yeah. So TD50 means the median dose which is producing the therapeutic effect. So, sorry, ED50 is the median dose that produces the therapeutic effect. TD is the median dose that produces the toxic effect. Yeah? You agree on this, right? Now let's assume this is the dose response curve for a drug. Okay? So this is the curve for therapeutic effect, which is efficacy, and this is the curve for toxicity. So at various doses, this is the toxicity. So many percent of patients are likely to have toxicity, and so many fraction, almost all will have therapeutic effect. Now, a question to you all is, you all were there in the first prescription session, right? Where we asked you to find out or write a prescription for a patient presenting with moderate obesity. And then most of you have chosen Orlistat. Could any of you recollect the dose that is mentioned in that book? 120 milligrams. How frequency? Up to 3 times a day. Yeah? Because I want to take you to this from what you know. So you all remember 120 milligrams up to 3 times a day, which means in a patient you can start with 120 milligram once a day, and if the response is not satisfactory, you can go to 120 milligrams twice a day. Even if that is not satisfactory, you can still increase the dose to 120 milligrams thrice a day, which means what is the dose range per day? If it is 120 milligrams once a day, it is 120 milligram. If it is going to be 120 milligram thrice a day, which is the maximum allowed dose, it is 360. So for all the drugs that you will be using in practice, irrespective of any specialty, it is not one dose which is going to do the magic, because variability is built in. Any physiological parameter, any biological parameter is variable, correct? Same goes with the response to a drug. That is also a biological parameter. So that also varies. So that is why any drug that we'll be using in human for any ailment will always have a range of doses. For Orlistat, if I ask you the dose, the range, it is 120 to 360 milligrams per day, correct? How did we derive this range? It's basically from this dose response curve. So for Orlistat, let's assume for Orlistat, you have this curve for therapeutic effect, which is reduction in body weight, and this curve is for its toxicity. Okay? For Orlistat, it would be 120 milligrams and 360 milligrams here, because the therapeutic effect starts with the, here in this graph, at 10 milligrams per day, and at 30 milligrams you see the toxicity starting. So the safe dose range is likely to be 10 to 30, which is what we most often refer it to as therapeutic range, therapeutic dose range. Okay? You all are there? Correct? No confusion. For Orlistat, this is likely to be 120 milligrams and this is likely to be 360 milligrams per day. Okay? Now, this is what we usually follow for all disorders. Okay? But for cancer, we need, it is, the dose range is defined slightly differently. The toxicity for anti-cancer drugs is further subdivided. For example, what are the toxicities that we get to see with Orlistat? Steatorrhea, good. Fatty stools. Deficiency of fat-soluble vitamins, very good. Anything else? Flatulence, okay. Do you think these are all something we can consider them as minor side effects? Which, are these going to kill that patient if they take? No. But if you take any anti-cancer drug, the anti-cancer drug will have a range of adverse effects where some are tolerable, like these are all called as tolerable. Flatulence, deficiency of vitamin D, steatorrhea, this can be managed easily. They are not going to cause death of patients. So they are called as tolerable toxicities. But you have something which is intolerable. For example, they can cause severe anemia, severe thrombocytopenia, meaning severe reduction of platelet count. So if the platelet count goes down, patient will bleed. So patient may die, right? So you classify the toxicity further into tolerable and severe. And intuitively, you know that if you have two such spectrum of adverse effects, the severe toxicities usually happen at much higher doses compared to the toxicities which can be tolerated easily by the patients. So now you have three curves. One is efficacy, which is the standalone, mentioning only about the therapeutic effect. In the toxicity for anti-cancer, we are splitting it into those which can be tolerated well and those which the patient cannot tolerate, those that can kill the patient, into severe toxicities. Agree? Yeah. So now, normally we take the last dose, the highest dose, as the dose that produces the toxicity in the previous one. But for anti-cancer, we allow those tolerable toxicities to be seen, to be encountered by the patient. The maximum dose that you are allowed to give it to the patient is the dose that is likely to produce a severe toxicity. So till this point, you are allowed to give the dose of the drug to the patient. In fact, let's say you have a patient presenting with obesity and orlistat dose range is 120 to 360 milligrams. At what dose as a physician, I should start this patient on? I should not jump to 360. I should always start at low and see the response and then titrate it to the next higher level. You all agree? This is the general dictum, right? You should not jump to the last. But in anti-cancer drugs, it is opposite. You don't start with the low and then see if the patient responds and go to higher. In fact, you start with the maximum highest dose and see if the patient is able to tolerate it. If the patient is able to tolerate it, maintain at that maximum high dose. Let's say you start with the 50 milligram, because after this you get to see the severe toxicity. So you start with 50 milligrams per day, observe the patient. Anything? Ahmad Mohammed? Nothing? So you start the patient on 50 milligrams per day and then see if the patient is able to tolerate the dose. Patient is able to not have severe toxicity. If the patient is not having severe toxicity, keep that maximum dose, 50 milligram per day as his standard dose. If the patient is not able to tolerate it, patient is having severe problems with that 50 milligrams, then you reduce it to 40 milligrams and see if he is able to tolerate it. So here, do you see the difference? How we manage other diseases and how we manage cancer. Other diseases, you always start with the lowest and then see the response to titrate to the highest. And there you will see the therapeutic response and go to the higher. But here you will start with the highest and see if the patient is having any severe toxicity. If the toxicity is there, go down. If the toxicity is not there, keep him at the same highest dose. Okay? Because anti-cancer drugs are going to affect the normal cells. The patient is going to have some problems. The problems are tolerable, keep it at the maximum dose. If the problems are not, if problems are going to kill the patient, try to reduce the dose to the next lower level. Okay, this is how it is different. This is called maximum tolerated dose. In anti-cancer drugs, it is always the dose is considered to be appropriate when it is tolerated. So the maximum dose which is tolerated is what is considered appropriate for anti-cancer drugs. Okay, so this is one difference. Yeah, so this is a clumsy slide. Don't worry. I don't expect you to memorize any names. Yeah, just to give you in a single slide, if I have to give you the different classes of anti-cancer drugs and the different names in each class, this is the best I could pull out, right? From you, what I expect is, don't focus any of these names unless you are really interested. Okay, if you are doing it, you are one step, ahead of others. But I don't expect you to know all these names at this point. You will come to know them. You will come to know them in Unit 4. You will get them know some names in Unit 6, in Unit 9, and by the end of year 4, you will be acquainted with most of these names. In this, what you should focus is the class. So the ones which are in red color here. So these are all the classes of anti-cancer drugs which are used for treating many cancers. Classes, right? So for autonomic nervous system, you remember we had cholinergic cholinergic antagonist, sympathomimetics, sympathetic antagonists. So like this classes. So here if you see anti-metabolites, anti-tumor antibiotics. You can use some antibiotics as anti-cancer drugs, alkylating agents, topoisomerase inhibitors. Just know that there are different classes of anti-cancer drugs. In general, any anti-cancer drug that you are going to take, any of the classes or any of those drugs, if you're going to see how the drug is acting as anti-cancer drug, the mechanism, it is going to be in one of the three pathways. Either they interfere with the synthesis of DNA or RNA or proteins, because they have to prevent the cell from proliferating. If the cells have to be prevented from proliferating, they should interfere with the DNA, RNA or protein, which are critical for the cell to duplicate and survive, synthesis. So all these anti-cancer drug will be interfering with one of these pathways: DNA synthesis, RNA synthesis, protein synthesis. You don't have to know the names of the target in this unit. Okay, you will come to know later in the curriculum. And in biochemistry, I am sure they have taught you about cell cycle, right? Any cell which is going to replicate undergoes changes at different phases. At resting, it is G0 or G0 or G0. Then it moves to G1 phase, where it gathers the materials which are required for replication of DNA, right? And it moves to the next phase, which is synthetic phase, S phase, where the DNA synthesis happens. And once it is synthesized, it has to go to G2 phase, where the proteins and the organelles will be synthesized for the cell duplication, and then it goes to the M phase or mitotic phase, where it separates into two cells, right? So you are familiar with the phases of cell cycle, G0 to G1 as G2 and M. Why? In what way is it important to us as anti-cancer drugs? We have drugs which are very good, which are specific to certain phases of cell cycle, and we have drugs which are non-specific, cell cycle non-specific. Cell cycle specific, meaning these drugs can act only when the cell is in that particular phase. You have drugs which can act only when the cell is in S phase. So they are anti-metabolites. So they bind to the DNA and they will prevent its duplication, and this happens when the cell is coming to the S phase. When the cell is in other phases, the anti-metabolites will not kill that cell. So that is the drawback, because at any time point you have cells in different phases of cell cycle. They are not going to be there at the same phases. They are going to be at different phases. Some will be in G0, some will be in G2, S, M, right? So when you are going to give a cell cycle specific anti-cancer drug, they are going to attack only when attack those cells which are having or which are staying in that phase. It is not going to attack the cells which are in the other phases. So that brings us to have a class of drug which can attack the cancer cell irrespective of whatever phases they are, and that is the cell cycle non-specific. So even when the cell is in G naught phase, when the cell is in resting period, the cell cycle non-specific drugs can act. But the other phases, they can never act in phases other than their target, and we do not have a class of drugs which can kill the resting cell. So the only class of anti-cancer drug that can kill the resting cells are cell cycle non-specific. You should be aware of this because, as I told you, in any cancerous tissue, you will have a population at different phases. They are not going to have uniform phases. Some will be in S, some will be in M, some will be in G2, right? So anti-cancer drugs are always used in combination. They are not used as one drug. You never will see in your practice that a cancer is treated by one anti-cancer drug. They will always be administered in combination. The reason is you will have a cell cycle specific anti-cancer drug. You will have one which is non-specific. So the non-specific will try to attack those in G naught phase and try to have influence on other phases which is not attacked by the cell cycle specific anti-cancer drug. So this is one rationale for administering the anti-cancer drugs in combination. Cancer is always addressed by combination chemotherapy. You don't use one drug to treat a patient. Okay, this is one rationale, justification. And anti-cancer drugs are always administered in cycles. Cycles meaning you give it for a few weeks, you give it for 3 weeks, and you give a rest. You do not administer the anti-cancer drug for 1 week. And then after that, you give it for 3 more weeks, stop, give a rest for 1 week, give 3 more weeks. In routine, we don't do that, right? When you're treating a patient with obesity, do you tell him, take this Orlistat for 3 weeks, don't take it for 1 week. Take it for the next 3 weeks, don't take it for 1 week. Do we give this advice? No. We don't do this for any other disease, right? But for cancer, this is how it is treated. Why? Why should that resting period be given? Why is not treated, he or she is not treated continuously? Affect him. Insensitivity. So the resistance you are saying, like if I have to bring an analogy, it's resistance. By giving rest period, would you counteract the resistance or would you increase the chance of cells developing resistance? Increase, isn't it? Yeah. No, logically thinking, right? Because now you are giving a time for the cell to think, oh, so how can I, develop mechanisms to counteract this anti-cancer drug which this patient is taking. Yeah, so you're giving them an opportunity. But if the anti-cancer drug is there, it will kill it. It will not have time to think about it, right? So by giving rest, you are actually giving a time for it to develop resistance. Okay, but the chances are very low. But it's a good thought. It's a good thought. You said the patients. It will affect the patient. Yeah. So any yes, Mohammed.
Doctor, you said that we will administer the drug 3 weeks, right?
In this example. Yeah.
Rest for 1 week.
Rest for 1 week.
The blue line is rest.
Okay. Okay. You can consider either way. So there are some things where you can give it for 1 week and give a rest for 3 weeks. Either way is possible. The concept is you don't give it continuously. You give a break. You take a break of giving anti-cancer drug. That's because yes.
The medication and prescription we have to know?
No names now. We don't expect any names to be known. Only the concepts, cell cycle non-specific and cell cycle specific.
The specific drugs usually come with the non-specific. They're usually together.
Yeah, so usually in any regimen, there is likely to be one non-specific and other two specific, but for different phases.
After we know the type.
Yeah. So no need to memorize any names, okay? So don't worry about it. All right. So the point of giving rest period, of giving anti-cancer drugs in cycles is they also affect the normal cells. And if you are going to continuously give it, the normal cells will be depleted so much that the patient will land up in having severe toxicities. So you need to give some rest period so that the normal cells will come back to close to normal state, and then when you start the next cycle, they will be at a close to normal state. So the patient is unlikely to get some severe toxicities. So always anti-cancer drugs are not administered continuously. So they are given in cycles, and some textbooks also use a word called pulse therapy. This is also called as pulse therapy. You give for some time, then you give a rest. You give for some time, you give a rest. So it's called pulse therapy or pulse intermittent therapy. All these are synonymous. Yeah, the rationalist, you need to give some time for the normal cells to come back to their normal physiological functions. Another concept that you should all keep in mind is, whenever you treat a cancer with anti-cancer drugs, which anti-neoplastic chemotherapy, they always kill the cells in log fashion, or it's called fractional kill hypothesis. Let's assume this is the time at which you have diagnosed the patient. So when you are presenting, we don't measure cancer cells, okay? Whenever a patient is coming to you, you don't take a sample of it to see how many cancer cells are present. No, we don't do that. It is just for your understanding, okay? Assume this is when the patient is being diagnosed as cancer, this is the total number of cells of the cancer tissue. Keep it 100%, 100%, okay? Let's say you give the first cycle of chemotherapy. Assume that it reduces 30% with the first pulse of chemotherapy drug. So from 100, now you have gotten rid of 30% of the cancer cells, so it has become 70%. Now you don't give anti-cancer drugs continuously, right? Because the patient will die in the course. So you are going to give a rest period, and during that rest period, the cancer cells will also have time to proliferate. So let's assume from 70%, in that 1 week rest period that you are giving, it has increased by 10%. So it has become 80%. So from 80, again it will reduce the same fraction, 30% of it, right? Assume it has come to 50%. So now you are going to give a rest period. So from 50 it will go back to 60. And then when you give the next cycle, it will reduce 30% of it, and then it can come back to 30. So every time when you give anti-cancer drug, it is the same fraction which gets killed. No more, no less. The same dose of anti-cancer drug is going to kill the same fraction of the cancerous cells. So this is the basis for what is called as log kill hypothesis or fraction kill hypothesis. In this, you can see this blue line, which is the number of cells of cancer if the patient is not treated by any modality. The patient is not treated by drug, no surgery, nothing was provided. Then this is how the cell growth is likely to happen, and somewhere here the patient will die because of the cancer. Whenever you identify the patient, if the patient is coming up with symptoms, right, already is late. He is coming somewhere at this point. So when the patient has symptoms, you can see the time that is left to die is almost very short, very minimum, right? So but you will start using drugs, you will start using radiation wherever it's possible, and then it can reduce the cancer cells, but eventually he or she is going to die. That's why we undertake screening procedure, right? Even if the patient is likely to be normal, you subject high risk patients above 40 years, patients who have frequent sexual intercourse for cervical cancer. So you identify such high risk patients and you ask them to undergo screening for certain cancers at regular intervals, so that if you identify them at early and start them on chemotherapy, you can even achieve cure. You can even achieve a cure. Only when it is only when it becomes symptomatic, it becomes too late, too difficult to get the maximum response. The chances of mutation is very high, and chances of having more mutations is very high later in the course of the disease. Okay, so that's why we always advise the patients to undergo high risk patients to undergo regular screening procedure so that you can identify even at the subclinical stage. It's called subclinical, even when they do not have a symptom, and then you can expect a miracle to happen. They can be even cured. Surgery. When you do a surgery, again you are removing a bulk of the cancer cells, right? So you can see if you do a surgery, assume from here you are doing a surgery, it can remove a bulk, and then you have to give anti-cancer drug because there are some cells which have escaped the surgeon. Surgeon is not someone like who has a microscopic vision, correct? So the surgeons have only naked eyes, so they can identify only the border which is visible to him, right? But some cancer cells would have escaped that border and would have gone to the peripheral tissue. Have you heard of metastasis? Yeah, in path they might have taught you, right? So some cells, they can cross the lymphatics, some they can cross the blood, venous compartment. Yeah? Lymphoma, correct. So they use these transport mechanisms and then they lodge to other tissues in the body apart from the primary site. This process is called metastasis. So these cells which have escaped, which cannot be removed by surgery, have to be also killed. So that's why even after surgery, you should still give anti-cancer drug at cycles, and that can take care of the remaining cells which have escaped the surgeon or which have escaped through the metastatic route and can bring a cure in some cases. So these are all the different modalities and the reason for doing screening, and these are all dependent on the fractional kill hypothesis concept. And here you can see when you don't give any drug, the proliferation is going to happen very fast and the patient eventually dies. When you are going to give one drug, there is going to be response. The response is minimum. When you add more than one, you can see the response gets optimized. You can expect better response. This is another reason for you to give anti-cancer drugs in combination. And you said cancer happens because of mutation, correct? And here the numbers you are talking about, could you imagine how many cells are likely to be in a cancer? Just to guess your GK. To what extent the number of cells is likely to be in a cancer? Any cancer, lung cancer, adenocarcinoma, colon, just the number of cells. Just guess, 1,000. 1,000 times 1,000. It's called Google. After this class, Google. Okay, Google, the word Google, Googol. Okay, so you will know the number, Google. So that number is the number of cells in most of the cancers, which runs into, have you heard of secdecillion? Secdecillion. So these are all some fancy terms they are using it. Okay, I'm not going to ask any questions. Don't ask me, are these important? Okay, just to give you an idea that you have so many cells of cancer in any cancer disorder. Okay, if you have to attack so many, you need to give them multiple drugs and you need to give them for a longer time. At the same time, the normal cells do get affected, so you need to give them some resting phase between for the normal cells to come back to do their job. Okay, this is important. In general, the anti-cancer drug that you administer in humans, you can classify them into one of three types: primary induction chemotherapy, adjuvant chemotherapy, neoadjuvant chemotherapy. This is important. What does each of these terms mean? Our patient, right? As soon as he was made a diagnosis of squamous cell carcinoma, right? Where? What is the lips? Okay, squamous cell carcinoma of the lips. What was he advised to undergo? Surgery. Did he undergo surgery? Yes. And after that, was he administered chemotherapy? Why was it given? Some cells might escape, right? So that has to be attacked. So you give chemotherapy following surgery. That is the type called adjuvant chemotherapy. Here, the type of chemotherapy that you are given is referred to as adjuvant, because adjuvant means what? It is just an add-on. It is not doing the main job of killing the cancer cells. You have done it by surgery. Here it is just adding on to the surgery, effect of surgery. So it is called as adjuvant. You will be seeing in unit 6 patients with leukemia, where you can't do any surgery, right? Surgery, you cannot take the blood and the bone marrow from all the bones, right? You cannot do any surgery. So there you have to primarily depend on the drugs to cure. So you will be using only the drugs to treat leukemia. So when the management of a cancer happens only with chemotherapeutic drugs, then it is referred to as primary induction chemotherapy. Induction means seeing a response. Primary means seeing a response mainly with the use of drugs. So that is called as primary induction chemotherapy, where you don't use any other, but you use only the drugs to get rid of the cancer cells. Adjuvant means you do something like surgery, radiotherapy. Following that, the remaining cells you try to kill them with drugs. That becomes adjuvant. Third variety, neoadjuvant, means you are going to take the help of surgery or radiotherapy, but here you are going to use the drugs before the surgery or radiotherapy, and then try to shrink the tumor cells with the drugs, and then you do the surgery to remove the remaining cancer cells, remaining tumor. So that becomes neoadjuvant. The difference between adjuvant and neoadjuvant is the sequence. If you are doing a surgery or radiotherapy followed by chemotherapy, as you see in our patient, it is referred to as adjuvant. If you reverse the sequence, if you give anti-cancer, reduce the tumor size, and then do the surgery or give radiotherapy, it is referred to as neoadjuvant. If you don't use surgery, radiotherapy, only the drugs, it is referred to as primary induction. Yeah, is that clear? So because cancer is such a nasty disease, no one should get it. Okay, given a choice, they should develop vaccine. Are you aware of any anti-cancer vaccine? HPV. One.
The one for the cervix.
Cervix, yeah, HPV, human papilloma virus. So very few. Like it's a dot that we have that can address the cancer, but you have many cancer types, right? So, but pharma companies will not allow anyone to find a vaccine because they depend on the revenue of anti-cancer. So they would put all hurdles to stop discovering anti-cancer vaccine. Nevertheless, so such a nasty disorder, you need to take help of multiple drugs, you need to take help of multiple modalities like surgery, radiotherapy. Only then you can achieve some sort of improvement in the lifespan, improvement in the quality of life. Okay, so that is the thing. But the great drawback of using anti-cancer drugs, as we keep discussing, are their adverse effects. What adverse effects are very commonly seen, which is pertinent to you as a general practitioner, is they are going to affect the normal cells. And amongst the normal cells, there are certain tissues in the body that proliferate rapidly, right? And you remember the bacteriostatic and the bactericidal. Why should they not be combined?
Because the cycle was correct from the beginning.
Good.
Sorry, the growth of bacteriostatic will inhibit growth from the
Beginning. So it will never go to the
because the
log phase, where they exponential phase, where they multiply rapidly, and that is the phase that are more sensitive to the bactericidal. So when they are multiplying fast, they are very sensitive to the killing effects of a bacteria. The same logic applies here. When you are going to use anti-cancer drugs, those tissues in our body which multiply fast, they are likely to be destroyed by the anti-cancer drugs. And of our tissues, hair, GIT, or very blood, all the blood cells, RBCs, WBCs, platelets, they are very fastly multiplying. Every day you have millions of them generating. So any anti-cancer drug, patients is likely to lose the hair. You have seen in many movies, correct? If not in the ward, many movies you might have seen patients with alopecia. The technical term that we use is alopecia. Patients, because of the effect in the intestinal epithelium, which is again rapidly multiplying, they come up with vomiting. Vomiting is not just one episode. You can even see the blood in the vomitus. So aggressive will be the vomiting. It is like coming from below. If you are given a choice of taking an elective, take it in an anti-cancer, taking a cancer specialty, just elective for a week or two. Yeah? So you will see how much suffering the patient undergoes, particularly even with the administration of all these chemotherapeutic drugs. Okay? So that vomiting, diarrhea, again, profound diarrhea is likely to be there. Patient will be anemic because RBCs, again they are very fast multiplying, RBCs will be going down, patient will turn anemic. And if a patient is anemic, what are all the symptoms you get to see? Always tired, right? Patient will be always lethargic, tired, cannot do any activity. Even talking becomes difficult, breathing becomes difficult, they cannot climb stairs, right? So their quality of life always, will be low. Platelet goes down, they will bleed. Even with a, normally if you hit minimal, nothing is happening, right? For them, even if this hurt, can bleed, can cause bleeding in the skin because the platelet is so low, right? So because of these problems, these problems you should be aware as a general practitioner. So when patient is presenting with any of these, you should know they are related to the anti-cancer drug which the patient is taking it. So there are ways, and of course we have a specific organ specific cytotoxicity which you don't have to memorize. Nothing has to be memorized here. Cisplatin, they cause autotoxicity, bleomycin. This is just later on when you are given when you are exposed to these names, you can come back to this picture and remember. Bleomycin causes pulmonary fibrosis. There is a drug called trastuzumab which is used for breast cancer. It affects heart. Cyclophosphamide, C. It affects the urinary bladder. Then you have a bone marrow toxicity, mycophenolate mofetil. You will be seeing in unit 6. It affects the bone marrow. This is just a picture for you to later come back here and keep in mind the organ specific toxicity. Right? No need to memorize anything in this unit, just for your reference. These toxicities you can try to reduce by several ways. The first is, these toxicities are related to dose, correct? Because in anti-cancer, how do you choose the dose? Do you choose the lowest or the highest? Highest. So eventually, when the patient is presenting with toxicity, it means the dose that you have chosen is high. So if you reduce the dose, it can also correspondingly reduce the risk of these adverse effect. But if you are keeping the same frequency, for example, we are giving pulsatile, right? We are giving in cycles. So let's say you are giving it for 1 week, giving rest for 3 weeks. But if now you are reducing the dose, you cannot give a rest for 3 weeks. So you have to increase the frequency. So either you have to give it every week or you have to give it every day if you are reducing the dose. And surprisingly, there are recent evidences which have shown that even by doing so, reducing the dose but giving it every day, or reducing the dose and giving it every week, has produced a satisfactory response similar to the maximum tolerated dose, and this is referred to as metronomic chemotherapy. So in some diseases, this metronomic means you're not going to go to the maximum dose because that is causing problems in the patient, severe toxicity in the patient. So you're reducing the dose but you are increasing the frequency, right? So this is in some cancers you can try to do this, and in some you can also identify the protein which is a mutant in the cancer cells which are not there in the other normal cells, and try to target that mutant protein, try to give local injection. For example, in lung cancer you can try to inject under the radiographic guidance, you can inject the anti-cancer drug inside the tumor. Melanoma, you can do so. There is a skin cancer called melanoma, malignant melanoma. You can inject the tumor only in that skin tissue. So by doing so, you can reduce the exposure of other cells to the anti-cancer drug, and you can reduce the risk of these adverse effects. So these are all the other ways by which you can ameliorate. And the last, until when the patient, you have identified them in the screening, or when the patient is at the early stage, curable stage, you can use these drugs to cure. But there comes a phase where patient has, the tumor has progressed or worsened so much, the patient is in the incurable stage. In that, all you can do is palliative care. So you can just try to address the symptom. Okay, patient has severe pain, you can give opioid analgesic. So that we have a class of drugs called opioids, morphine, codeine, pethidine. So these are all the drugs that can reduce the pain in such severe cases, and they also produce sleep. So the patient will have a good sleep at least. So at the end, when it is in the incurable phase, try to only give drugs that can take care of the symptoms. So that is referred to as the palliative care. Okay. Of course, you have to do counseling and strengthen the mental health of the patient as well as the relatives. Okay. So this is what I believe that you as an undergrad doctor should know. Do not bother in memorizing any names, not needed. We are not going to ask you the name of any anti-cancer drug. Okay. Know the concepts, how they differ from the regular management, maximum tolerated dose, giving in cycles, commonly noted adverse effects. Okay. And TD50, ED50 for others. Here it is MTD. Yeah. Any questions? Yes.
So, isn't there any herbal therapy?
Excellent. So what's your name?
Aisha.
Aisha. So Aisha is asking all of us, do we have any herbal medicine for treating cancer, right? Cancer. What do you guys think? Herbal medicine. Yes. Who said? You only answered the question. Okay. Okay, Aisha. So what are the herbal medicines you are aware of that can be helpful in cancer?
I don't know, but my cousin was.
All right. So this is a general question to you all because you raised it. Okay. Are we, like after you finish your MD, can you prescribe a herbal medicine? No? No? You won't. You can advise it. Depending on the type of the disease. Okay, good. I'll just see if there are any responses. As a doctor, you become Dr. Noor after 5 years, correct? Can you write in your prescription what herbal medicine you are aware of? Chamomile tea, right? Or silimarin. Can you write in your prescription? Will you write? No? No or don't know?
No, I'm not going to do it.
You're not going to do that. Turkey is also not going to do that. Yusuf not going to do that. You may, right?
That's amazing.
Maybe? Along other drugs, you would do that. Okay. My general question to those who are planning to do that. In your undergrad curriculum, what courses have you taken related to herbal medicine? Nothing. We don't know anything about that plant, anything about that molecule which you are going to prescribe. We never teach because even we are not authorized to do that. We should need to remember MD is for allopathic medicine, right? What we are doing is allopathy, not Siddha, not herbal, not we call it as complementary and alternative medicine, right? You cannot prescribe because if something goes wrong, the court will penalize you for prescribing it, So better do not advise anything, okay? To be on the safer side, say them you need to get consultation of a registered herbal medicine practitioner, and then you need to engage in discussion with them. See what you need to ask them. Okay, how is it going to act? Because it is possible it is going to interact with your medicine in the liver. So all this information we won't be aware of, isn't it? There are plenty of herbal. Okay, that to make you aware that you need to know you should not prescribe it. None of you should prescribe herbal medicine. Okay, but the answer to your question is yes. There are some evidences which say the herbal medicines are good, very well tolerable for some cancers. But I'm not aware of those because I'm not going to use it. So only those I'm going to use it. I will be keeping in my mind. But there are. You should engage in discussion with the herbal practitioner and then come to a consensus. Yeah, there are certainly there are. Like we should not be, this is another important philosophical question. Like what we are doing is only one type of therapy. Yeah. But it doesn't mean that other therapies are ineffective. There are many other therapies which can be helpful for the patient. It is just we are ignorant about that. So a concerned specialist should be aware and then we can discuss with them and then we can see what is the best approach for that patient. If you have a patient, you should do this. I'm glad that you asked this question because too early, I keep saying to Turkey, too early in the career to think about these nuances. Very good. Keep it up, Aisha. So here, you don't have to memorize any names. All you need to know is any anti-cancer drug, if you see the mechanism, it is going to affect either the DNA synthesis or RNA synthesis or protein synthesis. That's all. Okay. Noor.
So I just want, you remember last session I asked you about the FD.
Ah.
Why do we need to administer loading dose for drugs with high FD? So I
F-
revised,
VD.
oh my god, VD, yeah.
VD,
that's
right?
Yeah, I revised it and I came to the conclusion that we administer loading dose for drugs with high VD because they take more time to
Aiba.
achieve the therapeutic range.
Aiba.
And for high, like with longer
Half-life.
because they take also more time to
Very
achieve
good.
the
Very good. Therapeutic range.
the stable or the steady state.
Very
right?
good. Very good.
That's the only.
That's the
reason.
only reason.
Because for drugs with high VD, like the initial concentration, the more the VD, the less the initial
Excellent.
concentration.
Excellent.
And that is because
Because they go to peripheral tissues.
yeah, that's.
Yeah.
I just wanted to make sure.
Yeah,
That's-
yeah, very good. You're right. You're right.
Alright.
Good, Noor, good. So keep it up. Only 2 more sessions. I'll be seeing you all. I know there are some brilliant students. Come. There are brilliant students. Keep it up. Keep the same momentum till you finish MD.
Inshallah. Thank you so
Okay.
much, Doctor.
All the best. Hi.
I can't understand why if this is multiplying fast, it will be sensitive to healing effect.
Sensitive to healing,
I think healing. You said I didn't.
not healing.
I didn't hear.
This is normal cells.
No, this adverse effect.
Adverse effects, correct?
Yes,
Yeah. Adverse effects. Okay. Not healing to the anti-cancer drugs. They will be sensitive to anti-cancer drugs because